You're on, Rick.
Jake, would you like to just give some ground rules to begin with and introduce people to the control panel, etc.?
I can. The audience, thank you for joining us. We're glad to have you. You can send questions if you have any, non-case specific, please. You know, nothing too personal or specific to you. You can send them into the chat window, and one of the people on this call will answer the question if it's a good one. You will be muted. No one can hear you and no one can see you. Other than that, and the panelists and organizers know from our last 20 minutes how to use the control panel, and it seems everyone's got it mastered, with the exception of Alex, who can't get in with her computer. So that's it for me. Thank you. And I will. Rich Jackson and Joe Gallo and myself will be here. We're not going to be on camera, but we'll be in the background, monitoring and hopefully fixing any issues that come up, if any come up. But they better not.
So, my name is Rick Davis, and many years ago, I think around 2014, June maybe of 2014, I was sitting in a big auditorium. It was the Genentech auditorium at UCSF for the Prostate Cancer Research Day. And I was sort of towards the back, and somebody on the panel at the front acknowledged a gentleman who was sitting behind me, who must have snuck in. He wasn't there when I took my seat. And he had an English accent. And I wasn't used to that, hearing that sort of an accent in that environment. So when the break came, I walked over and I introduced myself, and it turned out that it was Dr. Alan Ashworth, who is on our panel tonight. And I walked over to him and I said, "Where are you from?" And he said, "Oh, he'd just come over from London." And when I asked him what he was doing there, he said, well, he was the new president of the Cancer Research Center and Helen Diller Comprehensive Cancer Center. That put me in my place pretty quickly. But Alan was, as always, so warm and friendly and unassuming, and made me feel very comfortable. And when we talked a little bit more, I'm not sure if it was on that occasion or the next occasion, it turned out that he knew my best buddy from England, who is a fairly well-known breast cancer surgeon. So we were able to connect on that level too. And I got to meet Dr. Munster also at a prostate cancer research day. By this time, we'd already started running some virtual support groups. We were running, I think, maybe 4 or 5 groups for prostate cancer. And I was very interested in seeing if we could start a group for inheritable mutations, particularly for the families, because we had had some experience of how inherited mutations can seriously impact family dynamics. And we've been working at that for probably 3 years. And this is sort of the culmination. And I am truly thrilled that ANCAN is coming together with UCSF and the National Ovarian Cancer Coalition to present this webinar today, and hoping that we will move forward and create a virtual support group. It's a great honor for us to be hosting this webinar. This is the second in our series. The first we hosted about a month ago, and we focused on prostate cancer. It was very, very successful. We had a number of peers then too, and we're doing one more for multiple sclerosis, which will be in September. ANCAN is really the home of virtual support groups. We've been running these remote video chat support groups, and before video chat, we did them on the telephone since about 2012. And we're finally gaining traction. We now have some 25 groups for 11 conditions. And we are very honored to partner with NOCC with an ovarian virtual support group. And that is how we come to be presenting here today. So that's a little bit about us, how come we came here, and I will hand over to Ilana Poista from NOCC to tell you a little bit about them.
Oh. Hi, everyone, and thank you for joining us here today. As Rick said, I am with NOCC. I manage the DC chapter, and I also run national programming, but I am a 6.5-year survivor myself with a BRCA mutation. I am delighted that we are here today with everyone who is on the panel today, giving you their stories and sharing their expertise with us. And I have the joy of introducing everyone. So I am going to introduce everyone, and when I'm done, I will turn it over to Professor Peshkin. So first, I'd like to introduce Dr. Pamela Munster, who will serve as our moderator. She is a professor of medicine at the University of California, San Francisco, where at the Helen Diller Family Comprehensive Cancer Center, she is leader of the Experimental Therapeutics Program, director of early phase clinical trials, and co-director of the UCSF Center for BRCA Research. In her lab, UCSF scientists are exploring new ways to detect, surveil, intercept, and cure BRCA-related cancers. In addition to her lab research, she develops novel strategies to treat patients with incurable cancers as an oncologist. She serves on multiple national, local, and international committees. Welcome, Dr. Munster. Joining her, we also have Dr. Jocelyn Chapman. Sorry, I'm hearing an echo. Dr. Chapman is a gynecologic oncologist, also at UCSF, and received her MD from Boston University. She did her residency and fellowship at UC San Francisco. She collaborates with Dr. Munster on research in ovarian cancer. And her specific interest is in understanding the molecular vulnerabilities in ovarian cancer with the goal to develop a test for early detection, which all of us who are on here would be thrilled for you to have. She will offer insight as a gynonc and share some of her research later. Our last medical expert on the panel is Beth Peshkin. Beth is a professor of oncology and the director of genetic counseling at Georgetown Lombardi Comprehensive Cancer Center. Professor Peshkin is nationally recognized for her clinical and research expertise. As a lead or co-investigator on several federally funded grants, her research has examined the effectiveness and outcomes of telephone genetic counseling, family communication plans, effects of internet-based decision support tools, and shared decision-making about multi-gene panel testing. Before she starts, I would like to recognize our 4 sets of family members who have graciously agreed to share their stories this evening. First, I'd like to introduce Maria Chesla and her daughter, Alex Cornwell. Alex is unable to show her face, but you will hear her story through the phone. Maria is a 22-year ovarian cancer survivor, and discovered she had a BRCA mutation 9 years after her diagnosis, which was also passed on to her daughter. Mario is a moderator with NOCC's ANCAN peer-to-peer support group on ovarian cancer, and she's involved in NOCC's Chicago chapter. She also had served as president of NOCC several years ago. I'd also like to introduce Nee Guttenfelder and her sister, Leah Reeves. Nee is a 3-year ovarian cancer survivor and a 13-year cervical cancer survivor. She and her sister both have a BRCA mutation. Nee has a podcast called Speak Gyno, and she is active in the NOCC chapter in Dallas. Leah, her sister, who also has a BRCA mutation, is a breast cancer survivor. We have Elena Solomon and her daughter Liz. Elena is an 11-year survivor of ovarian cancer without any known mutation, and Liz, her daughter, was in high school when her mother was diagnosed. Both of them are active in NOCC's Boston chapter. And finally, I'd like to introduce Craig McConnell, the widower of BJ McConnell, who is joined by their children, Ross McConnell and Corey Best. They lost BJ on March 1st after 4 years with ovarian cancer. She had no known mutations. And Corey has written a blog about her experience with her mom's cancer called Red Shoes. Thank you to each of our panelists and the fellow sponsors for participating this evening. Now I would like to turn it over to Professor Peshkin to tell us about her research on BRCA1 and 2 communication.
Hi, good evening. Thank you so much. I'd like to make a few introductory comments and then talk to you a little bit about our research. It's really a pleasure and an honor to be here. I'd especially like to thank the survivors and their families for joining us, and also to send my condolences to the McConnell family. I recognize that these are challenging times. We're here tonight to talk about cancer and family. And as I reflect on what's been happening with the pandemic, we recognize that individuals and their families with cancer have faced some unique challenges and worries in accessing care and being able to get and provide support to those who need it. Tonight, we are especially glad that you're joining us, taking time for yourself to get more information and ask questions. So with that, I'd just like to open with a few comments about hereditary cancer, tying together the themes for tonight, cancer and family. As I'm sure many of you know, about 21 to 22,000 women a year in the United States will get ovarian cancer. That means that up to about 4,400 of these women, or about 20%, develop this cancer primarily because they harbor a mutation or a harmful gene in a harmful change in a high-risk gene. Now, most women with hereditary ovarian cancer who have tested positive have a mutation in common genes such as BRCA1 and BRCA2, or other genes associated with Lynch syndrome. BRCA1 and 2 mutations increase the risk primarily for breast cancer, but also significantly increase the risk for ovarian cancer, as you know. In addition, there is an elevated risk for prostate cancer and pancreatic cancer. Several genes are associated with Lynch syndrome, which is associated mainly with colon and uterine cancer, as well as other cancers, including ovarian cancer. So there are definitely implications for men and women who have harmful changes in these genes. Mutations in these genes are passed down from parent to child. So each child of a parent has a 50% chance of also inheriting that mutation. Siblings also have a 50% risk. And once a mutation is identified in a family, you can imagine that potentially a dozen or more relatives may be at risk of inheriting it. One of the greatest benefits of genetic testing is that we can identify women who are at high risk of developing ovarian cancer. Because it is a rare cancer, relatively speaking, most women who develop ovarian cancer have no family history of it and had no warning. Even now, many women who test positive for a BRCA or Lynch mutation don't have a very suggestive family history of cancer. And for those women with ovarian cancer who test negative, the interpretation of that result can be complex and may or may not, for all practical purposes, rule out hereditary cancer risk. And I know there are a couple questions that have already been submitted about this, so hopefully we'll get to talk a little bit more about that. As many of you know, guidelines from many national organizations recommend that all women with ovarian cancer undergo genetic counseling and testing. This is because a positive test result may influence treatment recommendations. Some types of therapies may work better in women with BRCA1 and 2, for example. But it also allows for the identification of at-risk relatives, known as cascade testing. For women who test positive, removing the ovaries and fallopian tubes is the only proven way to reduce risk of dying from this cancer. Now the next step is to figure out better ways for prevention than this type of surgery. Going back to this idea of identifying individuals at risk for inheriting a mutation, it's predicated on the idea that once somebody tests positive, they communicate that information to their relatives. This is something that we'll discuss in a lot more detail tonight. But for now, I just want to say that in general, communication is higher in BRCA1 and 2 families than in Lynch syndrome. It's more often done by women than men, and to other women in the family than men. And it can be jump-started by turning points such as a cancer diagnosis, and can certainly be facilitated by healthcare providers, including physicians and genetic counselors like myself. At Georgetown, we've spent years studying whether and how moms in particular communicate with adolescent and young adult children about BRCA1 and 2 testing results. We found that about 50% of moms disclose their test results to teenage daughters, but lack confidence in knowing when and how to do this. We developed an education and decision workbook that was tested in a randomized controlled trial, and we found it was successful in resolving distress and facilitated disclosure of results to children. We're now about to start a multi-site trial of testing the workbook with peer support coaching to see if that improves outcomes and satisfaction with decision making. Ultimately, the goal of this research and the other research we're doing is to help make education and decision support more accessible to individuals, no matter how they get genetic testing, and to provide tools to genetic counselors and clinicians to facilitate improved decision making and informed outcomes. So I look forward to discussing these topics with you in more detail, and thank you for the opportunity.
Thank you.
Dr. Munster, I think.
Yes, Dr. Munster, you are up.
Okay, I'm happy to be up. So yes, thank you very much for this, because I think this is actually quite close to home for me, because in part is as an oncologist, we talk a lot about, you know, how are you going to tell your family members? How are you going to inform your children, your spouse on how you feel and what you have? And I learned this for a long time as an oncologist, but then I learned this as a BRCA carrier. As most of you probably know, I do carry a BRCA2 mutation. I had a very early form of breast cancer, so it's like I've been on both sides of the river, if you will, and I actually realized how difficult it is to actually have a communication. And I think I'm gonna ask you a little bit about, like, how does communication, how difficult was it when you were diagnosed for those who have a cancer, and how has this changed over the years, as there's really quite a bit more known about the BRCA mutation, Lynch syndrome. And I think, Beth, I think when you and I were starting with this, there was very little known about the mutations, and now I think this is quite a bit more accepted. So may I start with those who had cancer? How they put this together in terms of having cancer and having a mutation, and what happened? Just tell you a little bit what happened at that time. Who wants to go first?
I'll go first.
Okay. Mario?
No. And I'll try to shorten it as much as possible. So I was diagnosed at 27 with cervical cancer, and prior to that, a few months prior, my sister was diagnosed with breast cancer. And since that time, since we were both cured, both of my parents had cancer. My mom had breast cancer. My dad had cancer in his ear. So there was just a lot of cancer in our family. And just being involved in various support groups, I learned about genetic testing. So I brought that up with my family. It was highly controversial because a number of people did not want to get tested, and I wanted to get testing done. But whenever I spoke to my doctor, they said that it's the individual, because I know that the cervical cancer is not hereditary, but the breast cancer can be, that those individuals needed to get testing done. But no one in my family really wanted to get testing done. But I went ahead and moved forward with it. And it came back that I had 2 genes of unknown significance. That was in 2015. And then fast forward to 2017, when my gynecologic oncologist called to let me know there was an update, my gene was reclassified to a BRCA1, that I would need to come in for increased surveillance. 2 days after that conversation was when I ended up in the ER, and I had ovarian cancer. And so in our family, there's been so many people that have had cancer. In a way, it's not a huge surprise when one of us gets a diagnosis.
Thank you.
So this is Leah. I'll follow my sister. So when I was first diagnosed back in 2006, I was 33. I'm the eldest of six siblings, well, 3 sisters and 2 brothers. And at the time, my youngest brother was 17 or 18. And it was very hard for me to communicate with my family about that. My parents, first of all, were angry, and their response was less than positive. And I relied and leaned on online support groups, call-ins to online support groups, and it was very hard. I was in chemotherapy for 6 months, every 2 weeks. I relied on some strangers to take me to chemotherapy treatments, but and I'm happy to be cancer-free and thriving. And I was adamant on getting genetic testing because at the time, back in 2006, there were not laws, well, at least to my knowledge, that I was concerned that it would impact my risk in terms of insurance and things of my future, in terms just overall. And one of the things that I thought about was, okay, once I have that information, the next thing is, what am I going to do with it? Am I going to remove every single organ there is to prevent that if I do have that mutation? If I don't, okay, it's a huge sigh of relief. So I didn't go forth with that. My oncologist and my follow-up doctors kept on insisting that I get tested, and I said, no, I just don't want to get tested. I want to live my life. And so fast forward to when my sister Nee, when her gene got reclassified, she urged all of us to get tested, and I was still on the fence about it because I didn't want my information out there. I'm pretty private, and I went ahead and got tested, and it came back that I had the BRCA1, and this is 2020. I had preventative surgery, one last year and one the year before that. So here I am. I was that person who didn't want to get tested, but finally did.
This is Maria. I'll give our story. Alex, I think you've appeared, so we can share a little bit. In 1998, I was 51 years old, and I was experiencing symptoms. I would alternate between diarrhea and constipation, frequent urination, great discomfort on my left side, and but I thought it was all menopause. What I knew about ovarian cancer was Gilda Radner had died from it. That was the extent of ovarian cancer. One day, our son, who was still living at home, he was in college, said, "Mom, don't get upset, but you look like you're expecting." And it's nothing that you want to hear at 51 years old. We have 4 children, and Alex, who was on the call, was in high school. Her sister was newly married a year, and the 2 boys were in college. So that was it. It was my husband's birthday. I called our family doctor. He saw me and examined me. He said, "There's something going on. You've got to see your OB-GYN," which I did. He gave me the CA-125, which most of you know is the marker. And it was 56, which was higher, but not in the hundreds and in the thousands like many women are when they're diagnosed. So he said, just to be sure, I'm making sure you'll see a gynecologic oncologist. And I had one of the best ones in the Chicago area. He did see me. The surgery was scheduled 3 weeks after my first visit with our family doctor. They opened me up and on the left side, they found a perfectly formed large cyst in the left ovary. They said it's an ovarian cyst, but when they took it over to whatever they do, and the doctors could tell you a little more technically, but when they took it over to weigh it and look at it and cut into it, they found the ovarian cancer. So actually, the cyst had saved my life, and had it burst, it would have put me into a different stage. So Dr. Dolan suggested that I have 4 rounds of carbo and Taxol, which I did, got through it well, lived my life, and I had a shock about 9 years later. I was doing well, no recurrences. I'm of Polish heritage, and my cousin in Poland, who at that time was a professor of music at one of the universities, contacted me in a letter saying that not only did she have ovarian cancer, but this was a recurrence. And she had not let our family know because she didn't want us to worry about her. She was very, very much that kind of a person. So that she wanted to know what I did to help myself along during the chemotherapy, and I sent her all the information. But she also shared with me that not only was she dealing with recurrence of ovarian cancer, but her niece, my cousin, second cousin, also was dealing with ovarian cancer. And my paternal aunt, the mother of this cousin, had passed away, they think, from ovarian cancer, but things were still a little bit primitive in Poland as far as ovarian cancer diagnoses went. So I contacted Dr. Dolan immediately because they thought I had been sporadic, which is just an occurrence, means that ovarian cancer occurred in me. I did have genetic testing. It came back that I was positive for BRCA1. I did not have any trouble telling my husband or my children. I was tested in 2007, just before Alex's wedding. She was going to be married a couple of months later, and her sister was tested first. Elizabeth came back positive BRCA1 mutation. Alex was tested next. She also came back positive BRCA1. My brother was tested and came back positive BRCA1. I have 2 brothers. The other one has not been tested. Our son, one of our sons was tested and he came back negative. But when our niece was tested last year, my brother's sister, she came back positive BRCA1 also. So there's 5 of us in our immediate family that are living with BRCA1 mutation. It's interesting to note, I'll let Alex talk then, the way that I responded to it. I'm very much a proactive person, and I want to deal with things head on. And so it was not an issue for me in the sense of, oh my God, what's going to happen to me, even in the beginning when I was diagnosed with cancer. It was interesting with my brother's family that they felt that this was a death sentence. They feel this is a death sentence. And unfortunately, it's very difficult to talk to them about it. My sister-in-law is a nurse. The mother of the young lady is a nurse, and she's very, very concerned for her daughter. I just found the contrast very, very interesting. I'm very grateful. I have paid it forward with giving peer support to young women and young girls and older women who have been diagnosed with ovarian cancer. Was very active in NOCC, and I'm very happy to be in the support group that we have online, and I hope that I am paying it forward. Alex?
Hi, everybody. Can you hear me okay? Yeah? Okay. So yeah, as my mom had said, she had a very positive outlook on it. It was information that we could then used to our advantage rather than it being a really like a death sentence. So it was sort of knowledge is power. And so I actually just in November had my prophylactic double mastectomy. So I had my children, thankfully, gratefully was able to have my children at an age, I'm 39 now. And so back in November of last year, I was 38, had my prophylactic double mastectomy, and then I'm just healing from that, which was a little bit longer and slower than I had anticipated. And so once I'm really feeling 100%, I'll go in and do the prophylactic oophorectomy and most likely hysterectomy as well, just to kind of get everything out from that area. So for me, it was I think I was 27 when I found out that I had the gene. So I just immediately hooked up with a gynecologist, gynecology practice that was very proactive, and so they started me on the mammograms and breast MRIs and the CA-125s and ultrasounds. And most recently, the last couple of years, I've been going to the high risk group at Northwestern. And so they're tracking me, I'd say every 3 to 4 months with the ultrasounds and CA-125 for the ovarian cancer. So for us and for our family, thankfully, it's been a knowledge is power situation, and that's really been led by my mom. So both my sister and I are very appreciative that that was the outlook that she passed down to us. And all of, we're very lucky in that our families, husbands, siblings have been super supportive with all of it. And so we just try to stay as active as we can and try to talk other people through it and help others along the way.
Thank you. How about Elena and Liz?
Okay, I had ovarian cancer in 2009. 2 years before that, I went to a gynecologist. I was only 48 and I was menopausal, and she saw a cyst on my ovary, and she didn't think it was anything. And then 2 years later, I was just the thing that I was just having to go to the bathroom all the time. And then I got an ultrasound, and then they determined it was cancer. I had a genetic test after that, and nothing came up. My mother died of cancer at 56. They didn't know what the cause was because it was all throughout her body. My sister had breast cancer at 45. So 5 of my siblings have had cancer, and all different kinds of cancer. Out of 7, 1 died at 30, but not from cancer. So the oldest one is the only one that didn't have cancer. My sister had breast cancer at 45. I had ovarian at 50. My brother had prostate at probably 60. My other brother had appendiceal cancer, which is very rare, at 70, and he died shortly after that. And so someone said I should get tested again for Lynch syndrome. And I went to the geneticist again, and she said they couldn't find any mutations. But she said something is definitely going on in your family because 3 of my aunts had breast cancer. So she asked if I wanted to go on like tamoxifen, and so I went on that. But it's very weird. Breast, appendiceal, prostate. One brother died from lung cancer. Don't know what my mother died from, and I had ovarian. It's awful.
Liz, do you want to give your perspective?
So I'm not biologically related to my mom, so I don't know, anything about, my history or anything. But I think from everything that my mom has been through and her side of the family just makes me more aware of, going to doctor's appointments and checking on things when things don't feel right, and trusting your gut in those situations.
Thank you. So, Craig, you were the one who had to watch someone suffer from this. How did you communicate, and how did you communicate with your wife, and how did you communicate with your children?
Well, Ross and Corey and I are still, we're only 4 months post BJ's passing, so I think it's still a little bit raw, still a little bit difficult. But for the purposes of trying to contribute to this conversation, there is really no history of cancer in my family. My BJ's dad had prostate cancer, and in 2012, BJ had a breast cancer, but it was DCIS, and she was probably overtreated in 2012. But basically, the bottom line is that on September 23rd of 2016, BJ had an extremely severe pain in her gut. And as simple as that. Before this, there were no issues, no problems, nothing at all. As a matter of fact, we were 2 weeks post Ross's wedding, actually, and there just were no issues. But bottom line, we went to the doctor, had some scans done, and she had stage 4 ovarian cancer, CA-125 of 975. And I'm not exactly sure how to contribute to basically this conversation, but the first thing we did was that the 4 of us got together and we talked about what was going to happen. I forgot to share with you that in 1985, when Ross was born, BJ had her fallopian tubes tied. In retrospect, and learning what we've learned about ovarian cancer, we probably should have had her fallopian tubes removed. Never really thought about it at the time, but that was in 1985. But in answer to your question, my wife was a very forthright, very candid person. In September or October of 2016, she was given 4 months to live. I mean, she was stage 4 when she was diagnosed. So it was a little bit cumbersome, a little bit complicated, but she's the kind of person who we spoke frankly and candidly about what she expected to happen. We spoke frankly and candidly about death and dying. Ross and Corey and I knew exactly how she wanted to die. We knew exactly what the process was going to be. We had a couple of, there were lots of treatments, multiple debulking surgeries, 45 rounds of chemotherapy. I mean, she passed on March 1st of 2020. She was diagnosed in the fall of 2016. So we had an awful lot of things that happened in between there. Unfortunately, during that time, we didn't have a whole lot of quality of life, but I'm not sure that's an answer to your question, but that's kind of where we are. And maybe this is an appropriate time for me to sort of turn it over to Corey and sort of share with, let her share with you what she has done from her perspective as far as managing her health. So.
Sure. Hi. I have a 5-year-old who's joined me for just a portion. I am 39 years old. I have 3 children. 2 are girls. So when my mom was diagnosed, I guess I was 35. I went to see a gynecological oncologist probably within a year of her diagnosis, and decided to have my fallopian tubes removed because I was finished having children. I quarterly have a CA-125 test and an ultrasound. I am BRCA negative, so I do not have the mutation. But that's what I'm doing at this point to sort of manage my risk. And in my early to mid 40s, I plan on having a full hysterectomy.
You know, I'm not really, go ahead. I'm sorry, go ahead.
Ross, how was this for you? Do you want to share some of your thoughts if you feel up to it?
How is it for me? You know, I am one of those rare sons that I call my mom every single day. So it's been a kick in the teeth, but as my dad said, you know, the way that we have, I guess the way that we were transparent with this, never made it easier, but certainly helped us to wrap our head around what was possibly coming. You know, the conversations that nobody wants to have, the conversations that everyone avoids, and the conversations that everybody wished they would have had way too late, we did have, and we had them several times over. I think the tough thing for myself, my sister, and my father is, you know, as my dad said, I think we were actually a day back from our honeymoon after our wedding. And the past 4 years that I've been married, my mom had cancer. And it's weird because you want to think back, at least this is mildly my take on it, and I apologize if this seems a little skewed, but you want to think back of who that person was before the disease. And unfortunately, you know, I think my wife and I were discussing this the other day. My wife really got to know my mom once. And I say that because when we hung out and we lived in Arizona, that was probably the only time that my wife really got to experience the woman that we are trying to remember now. And I think that's what scares us so much, and what is so, I guess, painful is the disease becomes the person. And that's all you think of. That's all you talk about. And I don't know. It's, you know, I think Corey and I have had this discussion a couple times of, I'm starting to have memories of who she was before it. And I know that Corey is doing it with her own children, but I'm also doing everything in my power to make sure of it, that my daughter knows who she was through what my mom taught me. So, you know, I think what's so hard is the stigma associated with cancer, and what all of you just kind of expressed and told us. That's all you guys, not all you guys, sorry, that's not a fair thing to say, but that's how you talk. You talk about your CA-125, you talk about your treatment, you talk about how long you've been doing it, you talk about where were you when you found out. And I think, you know, if there's a goal, at least I have in my future, if anybody in my life gets sick, is to not talk about it all the time and to live, as my dad said, because my mom didn't. You know, she was a terminal student forever, and smartest woman I know. I'm sure there are many women on this panel right now that I'm looking at that probably could trump her, but that's not the point. But all she did was research, and it probably kept her alive a hell of a lot longer, because she found things that certainly I know that her doctors, even at Mayo, had never even thought of. But I do think that, unfortunately, be it breast cancer, be it ovarian cancer, prostate cancer, anything along those lines, life goes away. And I think that sucks. There's no other way to put it, you know, because I didn't, you know, I can attest that holidays, yeah, you're with your family, but you're not really with your family if all you're doing is wondering, how's mom? How's mom going to react to this? How's she going to be? Is this going to be okay for her? Can she eat this?
But
and,
we got to
you know,
have
I think
I get to interrupt because he's my brother. We got to have the holidays,
yes.
And I'm grateful for every single one that we had. Ross is too.
But I want to take I want to take this up here because I think it's actually a really important part because Ross, like you, when my father died of BRCA-related prostate cancer, all of my conversation with him was, how are you feeling? And, how is your pancreatic cancer going? And it took a lot to not see him as the disease, but to see him as a person who actually wants to talk about politics with me, and he was actually not interested in. So I think it's like for all of you are here because you want to take this forward. And so can you share with us what we can do, what you can do, what anyone can do in terms of communication, that the disease doesn't start to completely take over your life and personality? And I think that's what Ross is really bringing up, is like, how do we communicate as a cancer survivor, as a family member, that the disease is not all you are, but that you have the disease, but there's also a lot of the person. How do we do that? And like, I know this is really hard, particularly when you're struggling with chemo, when you struggle with the side effects, but I think that should be a part of our mission to help other walk through this. And what are the right questions to ask?
Well, I think this is probably not an answer to your question, but Ross's comments are a two-sided sword. I'm not going to talk about any medical facilities. I'm not going to talk about any specific doctors because that would certainly be very unprofessional. But every place we went, they already had a protocol in place. And if weren't willing to follow this protocol, they really didn't want you as a patient. And my wife was not the kind of person that was just going to accept that. I mean, many of the treatments she got, she found from clinical studies in Europe, clinical studies in the Far East. So the difficulty for us is that we were told initially, say your goodbyes, talk about death, talk about dying, because your mom's not going to be here very much longer. And my wife was not willing to accept that. So basically what she became is she became an expert on ovarian cancer, on clinical trials all over the United States, on clinical trials all over the world, via Foundation One, lots of things online. And unfortunately for me as a husband and Corey as a daughter and Ross as a son, it consumed my wife because she was doing the work that doctors who are so overworked, and again, this is not meant to be a disparaging comment about the medical profession. It's just a matter of there's only so many hours in the day. And so BJ made the decision on her own that she was going to become an expert, and she was going to try to figure out what kind of treatment might give her the best chance to have some quality of life as well as some longevity. And she was diagnosed in September of 2016, and she lived until 4 or 5 months ago. So we had some success, and we had some Christmases, and we had some holidays and Thanksgivings, and we had some good times thrown in with all the chemos and the radiations and the surgeries. She actually had 2 debulking surgeries, one of them specifically to create a personalized vaccine, which this is probably not the appropriate time to talk about that, but it's just hard when your spouse becomes so consumed with the disease herself, it's hard for her to live because she's trying to figure out how to keep herself alive. I hope that makes some sense. Now that I'm listening to myself, I'm not sure it made any sense to me, so it probably doesn't make any sense to you either.
Well, and from a child's perspective, that's all my dad did too. So for almost 4 years, he was a caregiver and just mom's assistant, basically, because she took on this mission of trying to figure out how to keep herself alive for as long as she could. And so he was lost in that too. So we don't really have a lot of good advice on how to not get lost in the disease. Maybe someone else does.
I guess I would like to give a little bit of input, because for me it's something that I struggle with, because I have been in active treatment since October of 2017, and we don't know if my treatment is working. And so I still, I go into doctor visits regularly, but I feel like it's a balance, because I have, I journal online. I have my Caring Bridge where my family and friends can log in and they can receive updates. I see a counselor regularly, so I have my outlets and my support. And I've reached out to, I've been involved with local support groups, and the women there have become friends. And so we'll go out to eat and we don't talk about cancer all the time. So I think it's nice to have friends who understand, and there's just an understanding. And then also I think of, well, the time that I have left, which nobody knows how much time, we don't know how much time we have left, but I think of, well, what impact do I want to make? Not just cancer related, what do I want to accomplish? And so when I think of when there is a finite amount of time, then there is a sense of urgency to pursue things that I enjoy. And so when there are good days, it's like, okay, I want to go out and take pictures or play with the dogs and just live life and really savor those moments. And it is a struggle. It's a balance because it's always in the back of my mind, but I still try to learn, to grow, and just get my mind, distracted, because there are a lot of things that we can't control that happen in our lives, but it's the meaning that we give to it, the bigger meaning. And I think just giving back to the community, being able to contribute, helps get my mind off of just thinking of myself, cancer, and treatment all of the time. That is what has helped me.
So I'm gonna follow my sister. And so for me, it took me a really long time I don't ask my sister how her day is or how things are going because she's living with it day to day. I let my sister lead the conversation if that's what she wants to talk about. And if that's not what she wants to talk about, then we can talk about the weather, about my garden, my other sister's garden, how I'm harvesting from her garden. And it took me a really long time to realize that, because I respect my sister. I want to remind her that we're still here. We're still above ground, so we're all successful and we're all happy, and that's just how I go about it with my sister, with my family. And I'm not as active in the area of advocacy as I would like. And it took me a really long time to get to this point, because for a very long time when I was first diagnosed, I did what Craig, what your late wife did, was research. I would go to doctor's appointments with 2 to 3 pages of questions. And my oncologist would say, Leah, you need to stop Googling things and reading up on, Journal of, Clinical Oncology and stuff like that, and, asking people all sorts of things. And, but I've come a long way from that. And at the time, I think one of the hardest thing for me was I kept on asking my oncologist what was the survival rate for triple negative, and he never told me. And recently I found out that the survival rate wasn't very good for the first 5 years, and it was a good thing he didn't tell me.
Thanks for your comments, everybody. I just had a couple of things I wanted to share, sort of reflecting from the doctor who treats a lot of ovarian cancers. To the McConnells, I will just say you sound like an incredible family, and she sounds like she was very, very lucky to have you. I know this grief is really fresh for you, and if networks like this are helpful to families who are dealing with the after effects of a death from ovarian cancer, then I sure hope that you find some solace here. But you guys have an incredible family, and you'll be fine. And I think it's just very interesting to listen to some of the panelists here talking and reflecting about how to communicate with your doctor. And in fact, one of the questions that came up was also how the doctors can help us facilitate communication that might be difficult. So I thought I would just actually open that question up to our patients and families here to see if there were any thoughts they wanted to share about that.
Well, much like Leah, we always went into the doctor's appointments with our own agendas. BJ would make up these, you've probably seen these big, gigantic 3x5 Post-it notes. We would walk in there, and when the doctor walked in, he knew that there'd be a Post-it note up on the wall because we wanted the agenda to be driven by us as opposed to by the doctor. And again, I sound like I'm being disparaging towards the medical community. That is not my intention. I just know how busy doctors are, gynocs in particular. So we would go into each meeting with very specific things that we wanted to address, as opposed to going into our appointment to be told by the doctor what he or she wanted to talk to us about. So in answer to your question, that was just something that we did, which we found to be very comforting. It gave us a little bit of control, and I think it put us, some doctors were offended by it. I've got to say that to you. In many cases, a lot of doctors would not respond to that very positively, but the ones that did respond positively, they would sometimes take BJ's Post-it notes and show it to their colleagues and say, well, look at this woman. How would you like to deal with her every day? But anyway, so that's one of the things that we did.
So can I call on Beth here for a second? Beth, you spend a lot of your time in and working on communication, and particularly working on communication on a very definable risk for cancer. Can you share your experience a little bit? What are challenging, what helps, what is easy, what is not easy?
Yeah, how much time do we have?
A couple of minutes.
Yeah. I mean, most of our work does center around communicating with children and young adults, and I do think that some of that translates to these other conversations. But one common thread of advice that I have when talking about sharing the actual diagnosis is to share the news gradually, like to feel out relatives and say, I've had some health concerns, or I've had some health problems, and I went to a doctor and I'd like to talk with you about it. And give people a little time to prepare for the news that you're about to share, as opposed to perhaps sending text messages or emails with a lot of information in it. And of course, that advice only tends to work when there is already open communication and some ease in discussing these kinds of topics. So I think that every family is certainly very different. When it comes to talking to children, and again, there's a lot we can talk about with this, but I think whether we're talking about sharing a diagnosis or sharing information about an upcoming surgery, be it for treatment or for prevention, or talking about a genetic test result, we try to remind parents that you have experience in many cases already talking about difficult things, whether it's talking about sex or drug use or problems that kids encounter, to think about where they are in their maturity level and what they can handle, and reminding people that sometimes the burden of sharing information with family can be overwhelming too, to not just be sharing information about a diagnosis, but answering everybody's questions. So it's okay to try to enlist other people in the family to help you with that. And it's also okay to say, I don't know the answer to these questions, or I need some time to process this myself. So
I'd like to add that I've always have felt that I'm a walking billboard for early detection. And if I could have it on my forehead, I would. And it was a gift that has been given to me, especially after listening to the McConnell story. And I'm just so moved by your story and by your strength. But I also feel that I had a mission, and I think that I am fulfilling it. I'm getting older, so I'm slowing down a little bit. But I'm always grateful to talk to women and girls who are experiencing symptoms. Of course, I do not give medical advice, but I say they have to see a gynecologic oncologist if they're concerned. Some of them have turned out to be ovarian cysts. Others have turned out to be ovarian cancer. And I have lost some friends in this movement. The woman who succeeded me at NOCC was also a stage 1, but a few years afterwards, she did not make it. So there's no guarantee that stage 1 is any better than stage 2, 3, or 4 in ovarian cancer. But you have to, I try to be positive. I have the support of my family and friends. I still have friends who ask me how I am. I had a wonderful gynecologic oncologist that I could share everything with at my appointments. I still saw him once a year until he retired. His successor is also very good for me. I see him once a year for my CA 125. I think that if you're given this gift and you're given this opportunity, you have to make the most of it, and you have to try to do your best to promote early detection.
Yeah, and just real quickly to add on to that, you know, my mom said her oncologist was amazing, and he was. But when I went to see him at 27, he said, go have your kids, go get married, go have your kids, come back and see me in 10 years. And that wasn't the route that I felt comfortable taking, or that my mom or my sister felt comfortable with me taking. So I went and found another practice that was more, was willing to start detection at an earlier age and monitoring it. And so that's just kind of goes to show about that piece, that just because the first doctor you go to, or even the first 2 doctors you go to, you have to find the one that feels right to you, and that is going to do what you are needing at that time.
And I think I want to weigh in on this a little bit. I think, you know, a relationship with an oncologist or with a surgeon is it's a long-term relationship about something that brings you actually quite close. And, you know, this is not everyone you get along with well. I mean, there's some people have similar temperament and ideas than you do, and others don't. And Greg, I'm fully with you. Is like if BJ had a clear idea what she wanted, she absolutely should pursue this, and she should go to doctors who are in line with this. At the same time, there are patients who do not want to take care of their own care. They don't want to research everything. They want to be taken care of. And I think that's okay too. And there's different physicians for that. And I think like in anything else in a relationship, a lot of things can go wrong. And sometimes communication is really important. I think part of this conversation is also like how to talk to your doctor, like how do you express what you like and what you don't like, and how do you feel comfortable. And I think as we wrap this up, is like I want to give Jocelyn a little bit of an opportunity to say, like, you know, how has the practice of oncology changed and shaped itself with patients being much more knowledgeable, and which I think is a good thing.
Yes, I totally agree. I actually, when people ask me why I wanted to do GYN oncology, I say, and it's true, it's the only surgical specialty that allows you to develop long-term relationships with patients. Most other surgeons, something horrible befalls a patient, they take care of them for, you know, the 6 weeks around surgery, and then they say, see you later. But for ovarian cancer, uterine cancer, cervical cancers, we maintain these long-term relationships with our patients, which I find incredibly rewarding. So ideally, as Pamela said, you know, no doctor can be the right doctor for everybody. So I firmly support and encourage the kind of advocacy that our other panelists are promoting here, to find the right doctor that speaks to you and listens to you and can help meet your needs. Another thing I wanted to touch on, because it actually came up in the question list, is how some of the ways that I think about trying to help facilitate conversations between my patients and their families. Because this disease affects women exclusively, and because it affects women oftentimes, especially with the BRCA or a hereditary mutation, and it will affect them when they're young. Corey and Ross are still young, and their mom was planning on seeing the grandchildren grow up and seeing everybody get married, and this is a very common time in life when women are healthy and still have a lot to do, and they are also the centers of their family a lot of times. With the strong ones that don't that hold everybody together and make the plans. And so I find with my patients oftentimes who have cancer are struggling with not only dealing with the logistics of their own diagnosis and how to manage the cancer and the surgery and the chemo, but then also how to lean on their families, which might be the first time in their life when they're actually leaning on them. So my suggestion to the person who posed the question, how do I talk to my son and daughter about this, and this is the advice I also give my patients, is to tell them that you do need their help, and this is how you would like their help, because people do want to help their family members usually. At least all of the families that I'm listening to on this call, they certainly seem to have really loving and supportive relationships, and so oftentimes it means the person who's not used to being vulnerable, the mom or the matriarch of the family, is now having to reach out to family members and tell them how she needs help. So I'm doing a lot of talking right now. I also know at the beginning there was some discussion about maybe touching on some of my research, which I will do very briefly because it's come up so many times about the difference between and the importance of finding an early detection test. I think everybody here has just reflected that the truth, which is that about 80% of ovarian cancer is diagnosed stage 3 or 4, and we know how hard it is to treat and even more difficult to cure. And so the challenge in this disease is really finding a test for early detection. Craig, I think someone mentioned how their wife had a tubal ligation instead of a self-injectomy, and indeed that is one of the things now that has been discovered in the last 15 years, is that ovarian cancers oftentimes will start in the fallopian tube, and these are microscopic cancers that will then float around in the abdominal cavity and attach and grow, and they are already late stage disease, even though the volume of cancer or the mass on the ovary is not so big. And so to me, the big challenge in this disease, and this is the focus of my research, is really knowing what's happening on the molecular level in those cells, those cancer cells, when they're really spread, when they're really early. And we know how that cancer is in communication with the bloodstream. And there are probably ways of identifying in circulation, even really, really small tumors, identifying some of the early molecular changes that are happening in ovarian cancer. So that's where our research is focused right now. And I will then scroll through a few of these questions, which are super interesting. Someone, I don't know if Dr. Ashworth is on the line, but there is a PARP inhibitor question that he does get on. The other question that came out that I think is a really interesting one, maybe Beth can field this one, is about how insurance companies handle the BRCA2 mutation and with respect to disclosure and whether or not it's considered a pre-existing condition.
Yeah, it's a great question. So as was mentioned, I think, Leah, your concern about genetic discrimination back in 2006. So in 2008, a federal law was enacted called GINA, the Genetic Information Non-Discrimination Act, which protects most people in this country against employment and health insurance discrimination. But it does not cover life insurance, disability insurance, long-term care insurance. So there are some, and I would consider GINA to be the floor of protection, not the ceiling. So the states may have additional protections in these other markets. And so if you want to consult on the NIH genome.gov website, there is a database that it's called the Genome Statute Legislation Database, where you can look up protections by each state. The bottom line so far, you know, in the many years that I've been doing this, we've heard of, and in the literature, there's been very little evidence that life insurance companies, for example, are very interested in this information. They're much more likely to underwrite based on the presence of a cancer diagnosis or a family history of cancer. They are not likely right now to ask you specifically about whether you have a mutation or whether there's a mutation in your family, but they are likely to get that information when reviewing medical records. So I think another part to that question was if you know, should you disclose the information? And the answer is, if you are asked, you should disclose it, because the penalties for not disclosing it could be worse. And again, it may be in your medical records. But we do encourage people to consider getting as much insurance as you're planning to get before getting genetic testing if possible. So perhaps get your life insurance or disability policies before getting genetic testing. If these types of insurance companies are interested in genetic information, it seems that they're probably more interested in things like predisposition to Alzheimer's disease, potentially, than cancer susceptibility results. So, you know, we'd like to see broader legislation and protections in place. Doesn't seem to be a big problem right now, but it's certainly important to be informed about what the regs are where you live and to think carefully about what you need before you get genetic testing.
That's great. Thanks, Beth. And I see Ellen on the line now. So we'll let field the PARP inhibitor question to Dr. Ashworth. The questioner is asking about the efficacy of various PARP inhibitors and whether or not the more recent second generation PARP inhibitors are thought to be more effective therapeutically. Do you have any insight into that?
Yeah, thanks, Jocelyn. It's a very interesting question. At this point, it's unclear that there's any major differences between the ones that are licensed for the treatment of ovarian cancer. They're all slightly different. We know of some lab properties that can distinguish them, but by and large, the licensed therapies are pretty much the same. Where it might be different in the future is when these are combined with other agents, because that'll be the next generation of PARP inhibitor treatments, combinations with various other agents.
Yes, and clinically anyways, and we have not had PARP inhibitors really compared head to head. So we don't have sort of a fair playing field to judge one versus the other.
Yeah, it's worth commenting on the different contexts, Jocelyn, of maintenance therapy and treatment. So treatment is when there's active disease. And then maintenance therapy is usually after the first cycle of carbotaxol, where many women have a response, and then they effectively are just observed until the disease comes back. In maintenance therapy, they're given a PARP inhibitor after the first therapy. It is very effective in holding the disease back. So half of the women who respond to a platinum-based therapy and then get no treatment, which is almost everybody formally, 50% of them would relapse in 12 months. Whereas with a PARP inhibitor, it doesn't even reach 50% in 4 years. So that's 4 years of disease-free interval. So that has far-reaching ramifications, and we're looking to build on that observation.
Wonderful. Thanks for that, Alan. One of the questions submitted before the webinar started was one that I think will be of interest, and I'll field this to Beth, or Pamela might have some thoughts as well. The question was from a patient who is BRCA negative, and she, I assume, or maybe he says, I understand I can't pass ovarian or breast cancer to my children. Is that true?
Okay, I can start, Pamela. This is also a very good question. Thank you for this. So when we talk about negative BRCA1 and 2 test results here, we want to distinguish between testing negative for a mutation that's already been identified in the family versus somebody, let's say somebody with ovarian cancer, as we've heard today, who may have had BRCA testing and was negative. If there's a mutation that is known to be in your family and other people are tested and test negative for it, if you're negative for that familial mutation, you cannot pass it down to your children, and that's really the best case scenario. And those types of results are very reassuring, and generally those individuals don't face increased risks of cancer that are associated with the mutation. There are always caveats. You know, we have to look at the other side of the family. We have to make sure that the testing was extensive enough. But perhaps this question was getting at somebody who was tested for BRCA1 and 2, has had ovarian cancer, and wants to know if that means hereditary risk has been ruled out. And the answer is not necessarily. So if people were tested for BRCA1 and 2, particularly years ago, and had ovarian cancer, it's time to consider updated testing, because we now know that not only the Lynch syndrome genes, but other gene mutations are linked with ovarian cancer. And so there's broader testing that can be available, or that is available. If somebody undergoes what's called a panel of gene testing and it comes back negative, that for all practical purposes may rule out a hereditary risk that we can identify. But in that case, and there's no indication then to test at-risk family members, but family members may still have an increased risk of cancer because of the family history. So genetic testing in that instance would unfortunately not provide clarification about risk to family members who are wondering about whether they have an increased risk. But we know that, you know, one of the things that we hope will be perfected over the next few years is something called polygenic testing, where we can look for combinations of genetic changes that probably account for a significant number of cases of ovarian cancer. And so by doing this type of more broad-based testing, we'll be able to better pinpoint ovarian cancer risk. That technology is not there right now, but for many individuals and families, that's probably going to be the key to better risk prediction.
If I may add to this, but there's a bit of a silver lining, and that's what we call the true negatives. You know, many times when I think of, like, did I pass on my BRCA mutation to my children, and what is the risk for my daughter to have breast cancer? It is reassurance to be able to say that if she doesn't inherit the BRCA mutations from me, her risk for breast cancer at young age is probably much reduced. And she then would really not start screening at a very early age, and she wouldn't have to do early risk reducing surgery. So I think the ability to tell someone their risk in the family is not as high as their mother or father is quite reassuring. And I think that's really an important part why I think testing is so important.
Absolutely.
And there's another aspect that I just want to say as from a physician side and from the patient side, is like, and I think, Beth, this goes back to communication, Jocelyn. Like, when you first hear about your BRCA mutation or that you have one, you immediately convinced that you will have breast cancer and ovarian cancer in the next few days. I think this is just this overwhelming sense that this now you have this risk, and you're gonna be at risk for breast cancer and ovarian cancer, and all you can think of is like, I need to get all of these organs out. But it's really important. That's the time where you need to talk to family members and really take the time to make good decisions. Talk to doctors you like and trust. Talk to experts in the field. And I think for those who learn that they have a BRCA mutation because they got tested because they have someone who was diagnosed with the cancer in the family, it's always hard to learn about your mutation. But it's also important that you take your time and do what's right for you, and what's right in 2020 may not be right in 2022. So it's important to think ahead. It's like, it's not an emergency. You're like, the BRCA mutation doesn't mean you have cancer. The BRCA mutation or like a Lynch mutation, any mutation means you have a risk for cancer. And I think sometimes this gets forgotten.
Yeah, actually, Pamela, just expand on that, because one of the questions was specifically what the percentage risk for breast and ovarian cancer was for BRCA2, for example.
I think the discussion has sort of like moved along a little bit. When I was younger, we thought the breast cancer risk for BRCA2 was less, and I think now we think they're both around 70%. I think we more agree now the risk for ovarian cancer is less for BRCA2, is maybe half of what BRCA1 is. On the other hand, BRCA2 is an enabler of many other cancers, so you see these sporadic other cancers that just don't at first glance make sense, like colon cancer, bladder cancer, all of these. Like I think Maria, you had mentioned small bowel cancer, if I remember correctly, is like or appendiceal cancer that we see, or even sarcomas and neuroendocrine tumors, and we weren't so aware before we started the testing. Beth, do you know about it?
Yeah, no, I agree. I mean, I think there are thousands of studies on cancer risks now, unlike when these genes were identified in the mid-1990s. And so, I try when I talk with people about this to not be overly precise in our cancer risk estimates, because the bottom line is that, whether the risk is for ovarian cancer, for example, is 13% or 20%, it's still by order of magnitude so much higher than it is in the general population. And where we would like to be where we'd like to be now, where we would have liked to have been 10 years ago, is to be able to give much more precise risk estimates than what we can give now, so that we can target people who can, help people decide when do they need to have their ovaries removed, do they need to have their ovaries removed. And unfortunately, even though we hear a lot about individualized and personalized medicine, we can't tailor these risk estimates nearly to the degree that we would like to be able to.
Right. I think I would just add to that actually human beings are not very good at thinking about statistics, because we are not statistics, right? So it either happens to you or it doesn't. That's your experience of it. You don't have a 50% chance of getting ovarian cancer. You either get ovarian cancer or you do not. So yeah, I think it can sometimes be a little bit difficult to put really, really precise numbers on it, because as I think the research improves, we will understand that if you have this specific kind of mutation in the context of a certain family history, then your risk might be different than somebody with a mutation at a different location on the BRCA who doesn't have a similar family history. So we might end up being able to be more precise than we are now. I'm gonna
and then just double back on that, Jocelyn. Like there's also your 3% a lot higher than the patient's 3%. I remember when I was going for my risk-reducing oophorectomy, and the ovarian cancer surgeon told me, well, you have a 3% chance of finding ovarian cancer. And I remember, as a physician, I would always say, well, that means 97% you're fine. As a patient, I was really, really convinced those 3% are quite difficult to deal with. So
yeah, I agree. I think we just have another couple minutes here, so I think maybe we'll finish off. There's been a lot of interest in the PARP inhibitors, so I'm going to address two questions kind of together. They're very similar, and Pamela can help me here too. There's a question about dosing and efficacy of PARP inhibitors. If you dose reduce to manage side effects, does that mean it stops working? And then the other one is using PARP inhibitors to prevent recurrence. Does that mean that cancer cells can become immune? So I think one of the more interesting points that these questions bring up is that, as Pamela knows, in investigational trials units, we don't study the maximum effective dose. We study the maximum tolerable dose. And as Alan, who's now on the line, knows, we in the lab, we give the cells, cancer cells, we can give them as much PARP inhibitor as we want to kill them. But in human beings, you can't do that. You're limited by toxicity. So drugs like chemotherapy or like PARP inhibitors, depending on a lot of personal characteristics about patients who probably don't understand how they metabolize medicines in their body, what proteins they have that help metabolize, they may tolerate not as high dose or less dose. That doesn't necessarily mean it's not effective for them. And I'll let Pamela and Alan chime in on any bits of that they wish to expand on.
Yeah, I think an important part is, like, if we're going back to what Alan said before, if you're looking at maintenance and you're hoping that you can give someone 40 months of a therapy, I think you need to be able to give at the dose that's manageable. If you do 4 cycles of adjuvant chemotherapy, where we know we can coach patients through to 4 pretty horrendous months, that's very different than when you try to give a drug every day for the next 3.5 years. And I think there is where we find balance. We will never know what a single individual person needs in terms of what's the optimal dose for an individual. So we all tailor from what we learned and what the approved dose is, and then go backwards from there. And I think, Alan, even in the lab, I think not every cell has the same IC50, and we find a balance.
Yeah. And I think that's absolutely right. The individual patient's metabolism is different, and how they manage drugs. We know that for all drugs. And so some patients get toxicities at certain doses and some don't. And we know of patients that have been on PARP inhibitors for 10 years with no side effects. So, so it's about managing it. And also the way that we do clinical trials, no one's ever done the trial where we don't give it continuously. So we do it every other month, and probably it will never get done. Because there's just too many parameters. But I would say any PARP inhibitor is better than no PARP inhibitor. That'd be my starting point. And probably a few drug holidays probably don't make any difference, I would say, my guess. And the second part was that, can cells become immune to the drug? Unfortunately, yes, we wish that this was a magic bullet that just cured the disease. In some women, it may cure the disease, but like all cancer drugs, sometimes the cancer can come back because it's Darwinian selection, and there are a lot of cells there, and all fates are already kind of written in the DNA. So sometimes there's a cell there that's resistant, and it might take a very long time, but it may come back, but not always. So one of the things that we're actively doing is to figure out what are the ways that cells can escape PARP inhibitor treatment, and then stop it escaping, so that we can have curative intent in all patients.
Yep, thanks for that answer. That's wonderful. Well, as we're getting to the end here, I might turn it over to Rick, who hosted this event, and thank you from myself. I really appreciate it, and I'll let you jump in and close things out.
Yeah, there was one question that came up early on that I wanted to pose to the panel, because I thought it was an excellent question about communication. It was sent to us ahead of time about how do you tell people in your workplace that that you have a serious cancer and that the cancer is progressing? Is it something you should share? You should not share? I'm wondering what thoughts the panel has on that.
So I have an experience about that. When I was first diagnosed back then, I was fairly young. I didn't know better. And I started work 2 years after I finished chemotherapy on remission. And all I got was, how are you? Not who I am, but how are you and your disease? And after that experience, I said to myself, you know what, that's more of a personal privacy, if you would. And from that point on, I decided that my personal life is going to be my personal life. My professional life is going to remain my professional life. And until I have that good, strong rapport and relationship with an individual professionally that I feel that I can trust and won't talk to me like, how are you, as in not me, but the disease, then no, I'm not going to talk about it. And I've kept that pretty strict in my professional world.
Thank you, Leah. Anyone else have any thoughts on that? I think it's a problem that so many cancer patients face, that they don't know what to share, how much to share. It's very difficult.
I guess I would just like to share a bit in that. I think I'm a little bit opposite from my sister. I'm pretty open and will willingly share any information. For me, I feel like it's part of raising awareness, and there are a lot of misconceptions about, especially, it's almost like a taboo subject with cancers below the belt, and that a lot of people aren't comfortable talking about it. And the way I see it is, if you don't talk about it, how are you supposed to learn? So that's how I see it.
Okay. All right. Anyone else before we close out?
Yeah, hi, this is Jake. ANCAN provides several online groups that you might be interested in. We have one for ovarian cancer. We also have one for caregivers. If you go to ancan.org, you can sign up for the newsletter and we will send you the notifications. And I suspect NOC and UCSF also have some support.
Thank you, Jake. Thank you for the, I didn't ask him to say that.
I can think for myself.
I think this has been an exceptionally useful and revealing panel, and also technical and very touching at the same time. We know that the conversations around disease within the family, that's a subject that is rarely spoken about. And the more we talk about it, the easier it is for the next lot of people coming on who have to face the problems. And hopefully this has been recorded, it will be published. And I so hope that many people in the future will listen to this and they will pick up some very helpful information. My heartfelt thanks to all the panelists, to the patients, to the doctors. We are just so grateful that you participated, because without you, we could have made this happen. And I also want to acknowledge the support that we got from Force and also from Charlotte, both of whom put it out to their membership. Thank you, everybody. I just hope at some point in time I can see some of you in people and see some of you in person and give you a big hug, which is what I'd like to do right now. And as far as Alan is concerned, Sheffield United had a pretty good season at the end of the day, Alan.
Yes, and we did get soccer back. That was one thing. So
there you go. All right. Alan and I know what we're talking about. Sorry, Pamela.
I just say thank you. I'm not a soccer person, but I appreciate it.
Okay. Thank you, everybody. Bye-bye.
Thanks, Rick.
Thank you. Bye.
Thank you.
Bye.
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 So
Ooh, Maria, are you still there?
I am.
Hi.
I
I just wanted to tell you I really commend what you're doing, and I really
Corey,
think it's really.
thank you. And I wish that your mom was still doing this. I really do. And I'm praying to a new angel. But
I think your attitude and your pay it forward is just really lovely. I was really
Corey,
touched.
thank you so much. And I'm going to be thinking of all of you the rest of my life.
Thank you so much.
Thank you. And thank you for the blog. You didn't really talk about it, but I think it was a wonderful way for you to express yourself.
Yeah, it has helped me tremendously.
Yeah.
Can you share your blog link, Corey?
Sure. I don't know. Let's see how I do that.
Let me see. I have it.
It's
Okay.
Wear Red Shoes, wear like WEAR, redshoes.blogspot.com.
Okay, I'll look for it.
Okay.
Thank you.
It's nice to meet everybody.
You and your family inspire me.
Oh,
Yeah, absolutely.
Hey, Rick, I also wanted to add in terms of the communication with cancer and everything. I know for my family, it was some of it was generational and also cultural too that got in the way as well.
Definitely. And you know, we see that with prostate cancer when we're working with different ethnicities. It becomes an issue in how certain ethnicities communicate their disease. So I truly appreciate that.
I know my mom did not want me to share with family because she feels somewhat I picked it up, but she never said it. I felt that she felt embarrassed, like, oh, you know, your family, you know, has a lot of sick kids and this and that, and so to this day, there are extended family who don't know that we have had and survived cancer.
Wow.
Yeah, that's what I said when I said primitive still in 2007 in Poland. It's made big advances, but my cousin didn't even share with us that she had the first occurrence, the cancer the first time. And it was so hard to learn that this was a recurrence, and she didn't make it. And that was even harder. But her niece is doing well and had just had a stem cell transplant about 6 months ago. So she's doing well. But there are a lot of, it's like a stigma in many cases, and it shouldn't be that way.
That was one of the topics I was hoping would come up through the questions that didn't come out.
Yeah, it's not.
Yeah, I was gonna say something, but I know that there were some questions and things that were being moderated, and I didn't want to overspeak my time because it was only for an allotted time.
You have to do this again, Rick and Ilana.
Yeah. Well, we are. I mean, one thing we are definitely going to do with UCSF next year is another one of these just on inheritable mutations. So we will have pairs where they know that there is a Lynch or BRCA or whatever it is, and maybe we can retain in our minds that we have the stigma issue to bring up, and maybe even the sisters would love to join us as a pair for that one too.
That would be great. That would be great.
You're welcome.
If we can, that would be good. Thank you for the opportunity.
Yeah.
It was wonderful. Do you know how many people were listening to us tonight?
I don't, but
at one point I looked, it was in the upper 50s.
Oh,
right.
that's great.
Not including the panelists, like just the attendees.
So
I think that's about right. We had 98 people sign up, but as Lana said, about 50 actually attended, which is a pretty good turnout, actually.
Is it? I was wondering. That's great. Thank you all.
Okay.
If it's
thank
okay,
you
I'm
so
gonna stop
much.
the recording now. Is that all right with you, everybody?
Yes, please do, and we'll talk to you all soon. Ilana, I'll talk to you. Thank you, thank you. You did a
Are we
great
on
Thank you.
for
Thank you
Wednesday,
so
Ilana?
much.
Next Wednesday?
Yes, we are on for next
And
Wednesday.
are you going to moderate then? Will
lady.
you-
I think so. I don't know if I put anything out there, but I can moderate.
Well,
Will you be on
all
the
right.
call?